I'm Rick McCain, an orthopedist with a practice in Columbia at the McCain Orthopaedic Center. In the course of your daily practice, you're going to see a number of patients that fall into the area of my specialty. I'd like to describe for you today 4 common complaints, 2 in the shoulder and 2 in the knee, that you can treat in your office with just the application of a few basic techniques with good results. Most common complaints that patients exhibit that have an orthopedic solution are ones we often hear at cocktail parties. Doctor, I have this pain in my right shoulder that I've had for 3 or 4 weeks and it's not getting any better. Or, doctor, I think I'm getting tennis elbow and I need some help. But these common complaints are generally the first indication we have that there is something wrong that we can easily treat, giving our patients the results that they want. This is why I've prepared this brief presentation for you today. Why don't we go to an exam room and see some patients? Let me introduce Chris Mosley, a friend of mine and current patient, who will help me demonstrate some of the physical findings today. One of the most common complaints we hear is, Doc, I've had this shoulder pain for 3 weeks, it's not getting any better, and it's worse when I lift my arm over my head. This is most probably rotator cuff tendonitis or impingement syndrome, and what I'd like to do is use this shoulder model given to me by a local rep to demonstrate the pathophysiology. You know the anatomy, the humeral head and the glenoid cup, and the rotator cuff system, the subscapularis in front, the supraspinatus on top, and the teres minor and infraspinatus behind. What occurs in rotator cuff tendonitis is muscle imbalance develops. This allows the humeral head to ride up under the acromion, pinching the rotator cuff. This produces pain, which leads to more muscle imbalance, more upward migration, and a vicious cycle ensues. What we try to do is rehabilitate the rotator cuff and scapular thoracic muscles. I'd like to demonstrate the physical findings of impingement syndrome now, and I'll always ask the patient to lift their arm over the head. So Chris, if you'll do that for me, and there'll usually be some pain at the mid portion of this forward flexion of the shoulder. It's always a good idea to check the passive abduction of the shoulder, and so I'll just ask, I'll stabilize the scapula and ask the patient to let me lift his arm out to the side, and you usually want to see about 85 to 90 degrees of passive abduction. Then we want to check for rotator cuff tendonitis in the rotator interval, and I'll usually palpate the anterior to the anterior lateral edge of the acromion, and on the involved side there'll usually be some pain in that area. Then we want to check the rotator cuff strength, and I'll ask the patient to tuck their arm into their side and then to pull their arm towards the midline, and then Chris, if you'll do that for me now, towards your midline, and that's about 5/5 strength there. Again, with the arm tucked into the side, I'll ask Chris to move his arm away from the midline, move it away from the midline, and in a patient with this problem, I would detect usually a little weakness there, about 4/5. We want to then check the supraspinatus strength with the elbow straight and the thumb down. Chris, now lift your arm up towards the ceiling, and usually there'll be some weakness of abduction of the shoulder, about 4/5. Lastly, we'll want to do the impingement signs for the shoulder, and these are done as I, for example, lift his arm over his head. Now Chris, let me lift your arm up. And as we bring the arm up in forward flexion, this takes the greater tuberosity under the acromion, and this will usually be a painful maneuver for the patient. And then lastly, we'll want to adduct and internally rotate the shoulder. Again, as this acromion comes in contact with the greater tuberosity, there will be pain, usually a grimace on the patient's face, in indicating some impingement of the shoulder. Of course, it is a good idea to perform imaging studies. These would include plain x-rays, an AP, lateral, axillary view, and possibly an outlet view, and also occasionally an MRI scan is indicated. Treatment involves activity restriction such that the patient keeps their arms low and they do not raise their arms over their head, producing the impingement position. The second aspect of treatment is for you to prescribe an anti-inflammatory medicine of your choosing. The third aspect of treatment involves an aggressive daily rehabilitation program of the scapular thoracic muscles as well as the rotator cuff tendons. And lastly, an occasional judicious use of cortisone. And I will inject about 4 cc's of celestone and 4 cc's of lidocaine in the subacromial space when the patient has plateaued in their recovery. I'd like to demonstrate how that is done today. I use this model for the demonstration, and I'll palpate the posterior lateral edge of the acromion. I'll come 1 centimeter inferior and 1 centimeter medial to the soft spot. With the patient sitting and relaxed and facing away from me, I'll bring the needle up into this soft spot area, up into the subacromial space anteriorly, and inject the material, usually with significant pain relief. The patient, of course, continues their rehabilitation program in the other treatments we indicated. You'll now see some images of rotator cuff pathology. Another common complaint we hear is, "Doc, my shoulder's gotten painful and stiff and I can't reach behind my back." This most likely is adhesive capsulitis. What I'd like to do now is move to the model again to demonstrate the pathophysiology. Adhesive capsulitis is more common in women. It can be bilateral. It involves 3 phases, and the first phase is the phase of pain and inflammation, followed by the second phase, the phase of stiffness, and thirdly, the phase of recovery. And each of these phases can last from 1 to 4 months. In adhesive capsulitis, an inflammatory reaction occurs in the inferior glenohumeral joint capsule. This prevents abduction and external rotation of the shoulder, and it is a painful and disabling condition. The physical exam is demonstrated by a hallmark of restriction of passive range of motion. And I'd like to go over some physical findings at this time. Chris, if you'll raise your arm up over your head. And in the patient with adhesive capsulitis, there'll be a limitation of active forward flexion, usually to about 140 degrees. And then I'll usually stabilize the patient's scapula, and then I'll ask the patient to relax, and then I will abduct their arm myself. And usually there'll be a limitation of about 45 degrees in passive abduction of the shoulder. Adduction and internal rotation is also good to evaluate, and so I'll ask the patient to take their thumb, and for purposes of demonstration, Chris, take your left thumb and run it up your spine in the back. And usually, as you can see here, there'll be a limitation of adduction and internal rotation in the patient with adhesive capsulitis. As usual, it's a good idea to perform imaging studies. The treatment of adhesive capsulitis involves aggressive, regular outpatient physical therapy. This is done at least 3 times weekly at a private therapy clinic. Patients are usually unable to do this type of therapy at home. An anti-inflammatory medicine is helpful to alleviate inflammation and discomfort associated with that. An analgesic medication prior to the therapy treatments. In refractory patients, closed manipulation of the shoulder is considered under general anesthesia in an operating room. And those patients that fail that, arthroscopic lysis